All right, guys, we have a special guest for you today. This is Nick. It's Norwitz, right?
Yeah.
Nick Norwitz. What would you say your overall specialty is so that they can get a better sense as to who you are?
Well, my PhD is in human metabolism. I did
Okay.
my undergrad at Dartmouth in cell bio and biochemistry. And then after undergrad, I went to Oxford to do a PhD in human metabolism, mostly focused on brain metabolism, but we did a lot of whole body work as well. And then after my PhD at Oxford, I went to Harvard Medical School, where I am now in the final year of my medical doctorate, my MD. So throughout that journey, I've done a lot of work from muscle physiology to, nutrition studies to brain studies to bone studies. But right now, my area of expertise is in metabolism, low carbohydrate diet, and lipid metabolism in particular. So
Nice.
cholesterol.
And the reason I'm reaching out to you and the reason that I want my audience to hear from your perspective is because there are a lot of things that I see in the nutrition world right now that are just kind of accepted blindly. A lot
Mhm.
of things that people don't think too hard about. They've been told how to think they've been told what to think rather than how to think. And the thing I really appreciate about your platform is you very much encourage people, like your whole thing is be curious, like,
Yeah.
and always trying to figure out the next thing, trying to figure out why things happen rather than just blindly accepting something that's been the convention for a very long time. So I have some interesting topics that I'd like to discuss with you, the ones that pique my interest and the ones that I know would pique the interest of my audience. So let's start off with something a little bit juicy.
All right.
There have been I've seen the reason I came across you in the first place was because of the fact that Dr. Layne Norton he was not a fan of the Oreo study that you did, and that was one that kind of made big headlines. I'm guessing it probably was one of the things that accelerated your platform quite decently. Um, so I'd like to hear overall what the Oreo study was, what the controversy behind it was, kind of your overall take from that scenario in general, and how it is going to relate to future studies, in your
Yeah.
opinion.
So I'll frame this up by the headlines ran something to the effect of like Harvard scientist lowers his cholesterol with Oreo cookies. And before I even get into why I did the study, I want listeners to pause and audit what their emotional response to that is. Because there's a spectrum of pretty predictable emotional responses. Everything from this is absolutely absurd to, well, this is interesting. What's going on here? And it was the latter response I was more interested in. Now, why I did it in the first place was quite transparently and openly provocation. The fact of the matter is, I and colleagues have been studying, or colleagues and I have been studying this really, really interesting phenomenon that happens with respect to specifically to low, lean people who go on low carb diets with respect to their cholesterol. We can get into that in a minute, but we think this has revolutionary potential. However, our resources are limited in part because this is a discussion that some people are trying to suppress and or hinder. And when I use words, just so you know, because I guess not all your audience will know me, when I use words like suppress, I use them very intentionally, not hyperbolically. So we can go through examples of what I mean by that, including in the peer-reviewed literature. But that aside, the intention was provocation to get people to look at this phenomenon where I actually did legitimately lower my cholesterol with Oreo cookies in a very rigorous manner and predictable manner, and then ask the question, how did I know this was going to work? What did I know about physiology in a particular context, which we will unpack, that enabled me to pull this off? Because when someone else can predict an outcome that to you appears unexpected and paradoxical, it means there's learning to be had there. So this was a very carefully engineered project in order to promote engagement. You can call it legit bait if you want, because I wanted people to look and turn their heads and say, well, wait, what's going on here? And then delve down the rabbit hole of our other literature. So that was the overarching purpose of the study. Basically, what I did was I had a run-in diet just on my normal ketogenic diet. I've been on a ketogenic diet for a long time. Then I added in Oreo cookies, 12 cookies per day on top of my diet. It wasn't a swap, it was a pure addition on top of a rigorously controlled diet. Did that for 16 days. Then I had a washout period to kind of reset and then compared the cookies to high dose statin therapy. And basically what I showed is that in a particular context, metabolic context that I engineered, I was able to drop my cholesterol with Oreo cookies by 71%, my LDL specifically by 71%, the so-called, quote, bad cholesterol, as compared to 32.5% with the statin. So I legitimately lowered my cholesterol, my LDL, by 71%, twice as potent as high-dose statin therapy in one-third of the time. And that
So
was based on our understanding, me and colleagues. Go ahead.
So was that an extrapolation as far as the statin goes, or did you also do the statin as
No, I
well?
did the statin. No. I legitimately, I did the statin, 20 mgs of Crestor, that's rosuvastatin, for 6 weeks. This was all also, this wasn't like I wrote a blog after the fact. Like I announced this would happen, and I went to Harvard's Institutional Review Board, the IRB, got the IRB exemption. My primary care provider, my GP, was ordering all my tests directly into my electronic medical record. I was getting them drawn at Harvard hospitals. I had a consultant lipidologist on board, Professor William Cromwell, who's been doing lipids for 30 years. I know how to dot my I's and cross my T's. My background is as an academician, a PhD researcher. So the purpose of the study was to provoke people to turn their heads and say, what's going on here, and then engage with the literature. I will say, to the credit of the overall community, that is what happened. We have developed research relationships, acquired resources to do further projects as a function of this stunt, effectively. And I've corresponded with clinicians around this. I've been speaking at academic conferences where I mention it. I've had cardiologists reach out to me and say they became aware of our work because of the Oreo versus statin study and now can use the principles of our models to treat their patients with even sweet potato therapy as compared to statin therapy. So they're like, instead of giving a patient a statin, they will give them sweet potatoes if the patient fulfills a particular set of criteria, which again has to do with our work and how we understand lipid dynamics to be changing in a low carb context. So it's all about understanding the root cause physiology and then, at least in a clinical setting, providing informed treatment approaches or having informed conversations around whether treatment is needed. So this was kind of like a spear tip to get people to look at our literature. I'll
Now,
pause for a sec for questions, and I realize I kind of dodged your question about Layne. I'm happy to answer that as well.
oh no, not at all. So I guess just for my audience, because they obviously haven't seen, or most of them wouldn't have seen the study that you did on yourself, what was your LDL at the starting point, and what was it by the end of the experimental time with the Oreos?
384 as a starting point, and it went down to 111 milligrams per
Okay.
deciliter. So no, it tanked, and that was 16 days. I mean, that's
Yeah,
more potent than you'd expect even like a PCSK9 inhibitor to be, Repatha, and much,
right.
acting as fast as you possibly could imagine. I will clarify the context in which we're talking here is something called a lean mass hyperresponder phenotype, where very high level, when lean insulin sensitive people go low carb, you see this massive shift in their lipids. It's almost always lean insulin sensitive people, and the LDL goes through the roof. That's what we've been focusing on, but it actually happens as part of a lipid pattern, a triad, where the LDL, excuse me, goes high, the HDL cholesterol also goes high, and the triglycerides tend to be very low. So you have this high LDL, high HDL, low triglyceride pattern, this triad, and that defines the phenotype we have. And this phenotype is very particular to lean insulin sensitive people, such that if you go and do, which we did and published on, meta-analyses for all the low carb trials with less than 130 grams of carbs per day. So even low carb, this generalizes to beyond just keto. And then you look by BMI category. So lean BMI, less than 25, versus overweight, 25 to 30, versus class 1 versus class 2 obesity. What you find is the only category where if you do the meta-analysis of human randomized controlled trials, we know some people who like RCTs, um, then the lean people have the increase in LDL. Overweight and obesity don't as a population. Class 2 obesity, you actually see a decrease. And if you use individual participant level data across randomized control trials, you actually find an inverse relationship between LDL and BMI, whereby the leaner you are, the higher your LDL goes, and the more extreme this phenotype. So this whole lean mass um, moniker comes from the fact that this triad that I said, the high LDL, the high HDL, the low triglycerides, emerges in lean people primarily. That's
So
where the
from
term comes from.
Yeah, so from a technical standpoint, when you're saying BMI, you are more so referring to the body fat levels of the individual, but obviously, you're probably not looking at exclusively bodybuilders who might be
Yeah.
30 BMI, but primarily muscle.
So there are extra nuances there. We are limited by the data we have available. So if you look at large populations and even these RCTs, like generally they will have weights and heights and BMI, so we can use those. Typically, participants are not getting DEXA scans for body comp at every time point. So we
Mm.
are limited in that. We did one study where we did look at body composition, and it also was a predictor. I would say if we had larger data sets with body composition and could look at different fat compartments, I'm sure the body composition would be a better predictor. With the caveat that there are additional things, related to our model that could be also influencing lipids. So, for example, if somebody's a bodybuilder type, there's an idea that if you are ripping up your muscles and needing to repair them really quickly, there might be structural demand on the circulating lipoproteins. And that might reduce the effect, which is why you might not see a ton of bodybuilder types with a lean mass hyperresponder profile. However, we do have people with BMIs above 25 who are very lean with low body fat who exhibit this phenotype. So, yes, that is possible.
Part of the reason I ask is because I did exhibit that phenotype specifically when I was in bodybuilding prep.
Yeah.
I would very much so exhibit that phenotype, exactly the numbers that you're looking for, but I haven't had a BMI under 28 since I was, I don't know, 16. Because as I built more muscle, it was just that I wasn't even at a very, very lean point. I'm not going to be somebody who's
Yeah.
under a 25 BMI.
Right. And all these things are based on population level data. So it's always your mileage may vary for the individual. I like to point out in general in physiology, like physiology, biology, they do not care about the cut points humans artificially create. So by analogy, like if you have an HbA1c of 6.4, you don't have type 2 diabetes or diabetes by cutoff criteria. And then when you hit that 6.5, you do. Your physiology didn't really massively change as a function of that 0.1%. It's just we created a cutoff so we can categorize things because you need to do that for our human minds and for creating categories for studies. So
Out of,
yeah,
out of
BMI is same.
Out of curiosity, what would you consider to be an HbA1c where you're starting to, obviously it depends on the individual, but is there a certain number where you start to get a little bit concerned when you see those numbers in somebody?
I think like anything, it requires a degree of context, directionality, how quick it's increasing, things that might be affecting it. Also the glycemic variability, so how much the glucose is spiking and dropping versus how flat it is. There are phenomenologies where you can have an increase in A1C with actually pretty stable blood glucose and lower insulins as a function of maybe more adaptation to severe carbohydrate restriction. The consequences of that, I don't know. What I would say is for something like insulin resistant type 2 diabetes, there might be markers you want to look at beforehand, before you'll see an increase in A1C, because the way the disease develops is you develop insulin resistance, and then your body's trying to compensate for that insulin resistance. Your tissue is not hearing the insulin signal by pumping up the insulin. And so insulin will be increasing along with insulin resistance. And all this time, your body's able to kind of compensate and A1C stays normal. It's only when that process starts to really fail later on in the disease process, years later, that you'll see the A1C rise. So, I wouldn't say a normal A1C is even reassuring when there are other things amiss, suggestive of insulin resistance. You kind of want to get ahead of it and prevent that insulin resistant, the A1C jump. So A1C is like a late marker to change in the development of insulin resistance in type 2 diabetes.
Okay. Yeah. So getting back to the cholesterol
Mm-hmm.
conversation, as far as so when you presented your data, when you presented this n equals one experiment, which is very which is pointed out a lot by a certain crowd. It's one person, it's one person. That seems to be the general, that seems to be the argument against it. Obviously, your model was more predictive,
Mm-hmm.
which is much better than if you were just taking a retrospective idea of it.
Yeah.
But what would you say is what's the primary confusion that's causing people to believe that these cholesterol levels are the primary driver of these issues rather than something that is just associative?
So I actually want to parse. the scientific mechanistic, what's driving up the LDL, from the clinical. We talk about the problem because these things can coexist. We could be 100% dead on about the lipid energy model and why this phenotype arises. And it could be natural human physiology, entirely adaptive in a short term circumstance, and still confer increased risk. Those possibilities can coexist. And I want to highlight that. But to get back to the whole idea of this is an n equals one, and that's a nice talking point, one thing people tend to overlook is what is a study trying to communicate? What are the claims being made? What is the purpose? And that is the only way, that is the frame you need to interpret a study. So we have this whole idea of a hierarchy, of like, oh, case series at the bottom, and then you have like uncontrolled trials, randomized controlled trials, metas, yada. I don't think that hierarchy is fair even because it depends on what questions you're asking. People like to look at the vanity metrics, the n value, the hierarchy of the literature. All of that is kind of hollow if you don't understand what questions are being asked and what claims are being made. So with respect to this n equals one, I'm not trying to change guidelines or prove anything about the general public's physiology. This was a clear n equals one metabolic demonstration, which, as you mentioned, I like you use the word predictive. It's like, yeah, this happened, but I also predicted it would happen, announced I would do this, went and got an IRB for it, and then did it, and I was right. So how could I have possibly guessed it would have worked? That means I know something. And I have a point I'm trying to make. And that point was about our broader literature, which points to things that are beyond the n equals one. So if you even want to play with that schema of the hierarchy, right? What's at the top? Okay, you have RCTs, human RCTs. How about the meta-analysis of human randomized controlled trials that we've done, where we show things consistent with the model, where leaner people have higher LDLs in association with this triad. There's an inverse association between LDL and BMI change. These fascinating things that are at, quote, this highest tier of literature. But here's the catch, which is before you heard of Oreo versus statin, I'm going to guess you had never heard of our RCT. I don't even know if you've heard of it now, our meta of RCTs, right? Because people aren't talking about it. And to some degree, that's understandable because it doesn't have the sensationalism around it. So put yourself in my shoes and think, if you have data that you think is important, that you want to have conversations about, including with academics and influencers who fancy themselves academics, and you want to force a conversation, what could you do strategically to force that conversation? Hence Oreo versus statin. That was the whole point. And the interesting thing was to what degree this was effective and to what degree it wasn't effective. Because some people came with very open minds to have conversations. So I'll give some examples. Simon Hill, he's handle at The Proof, prominent in the plant-based space. So we could be seen as like opposite sides of the aisle. We had a 5-hour podcast that was fantastic, got into all the nuances, or a lot of them. Even esteemed professors, probably one of the most cited nutrition professors in the world, Walter Willett, also very prominent in the plant-based community, H-index of over 300 at Harvard. He had me to his house. We talked about Oreo versus statin because he could appreciate what I was trying to say and what I was not saying and the purpose of this whole thing, and sit down with me as an intellectual and say, wow, this is interesting. What can we draw from this and what questions does it stimulate?
Yeah.
However, there are people that responded in a more disappointing way, where either they didn't see the nuance, which, or the purpose, and I can appreciate that, or they intentionally went out of their way to engage in their own form of less legit bait and more clickbait by misrepresenting the study as something that it wasn't. And you asked about Layne Norton, so I'll address Layne Norton. This is the category he falls into. And I say this with a degree of confidence because he was very much aware, I made him aware, of the research around this topic. In fact, we had a whole group chat that he opened with my colleagues, Professor Adrian Sotomota and Dave Feldman, to talk about our meta-analysis of randomized controlled trials. That was the whole point. Now, you frame that with the fact that he always boasts about how much he likes to talk about randomized controlled trials. You think he'd do some degree of coverage of that, rather than ignore it completely. And then on top of ignoring it completely, misrepresenting even the physiology of the Oreo versus statin study, which he asked about, we explained, it was in the paper, and then he screwed it up. Which is just kind of lazy and in poor form when you tack onto that as well. He went through the effort to make a video on his own time when we would have had a discussion we offered up ourselves as discussion partners or esteemed colleague lipidologists Professor William Cromwell. And on top of all of that, if you want a kicker, or a couple kickers, I had reached out to him before we published Oreo versus statin. I offered to show him the discussion section of the Oreo versus statin paper before it was published to get his commentary and said I would acknowledge him for it. Why did I do that? Because it's pretty obvious he's a predictable character, what he's going to do. He's going to jump on it because it's great media bait, and I prefer to have him as an ally rather than an adversary. And I thought we had the groundwork laid for that, and then he went and did coverage that you said he didn't like the Oreo versus statin study. I'll be dead honest, I did not see his video as an attack. If people watch it, and you can feel free to, he wasn't attacking me. And he even said at points in time that the researchers aren't making X, Y, and Z claims and then nut picked individuals off social media and chose more extreme claims. So to be very clear, I didn't feel attacked per se. I was just disappointed and felt since this is our literature that we've bled and sweat and shed tears for, that it was fair to correct the record on some areas that he did air, including areas of physiology. He said, you know, a certain finding contradicted lipid energy model. I'm like, you asked if it did. I explained why it didn't. It's in the paper why it didn't. So let me correct the record on my own data set. He did seem a little bit upset, or more than a little bit upset, that I went out of my way to correct him. And I'm not hiding my rebuttal video. People can check it out on my channel. You can link it if you want. I didn't shout. I didn't yell. I just got to the matter of the data, which, you know, if he fancies himself an intellectual, he should put data over feelings, which was also, coincidentally, literally the shirt he was wearing during the video. So I thought I should have the liberty to, you know, say, you tried. You could have done better. We gave you these opportunities. These are the things you missed. Here are some corrections. Data over feelings. Let's have an elevated discussion. Quite frankly, I don't think he responded well. I will address the matter of my perception of his interpretation because I know it will come up, which is he felt I responded with poor timing during a time when he was having a difficult personal matter. What I'll say to that is I'm always sympathetic to people who are having difficult, you know, personal times, but I responded to him basically in real time when he posted. So he posted on Instagram and Twitter at a point in time when he was having a family crisis. Then I responded to matters of the data. It was his choice to post at that time. You know, my response was timed with his response. So I responded to his comments on our data. So data over feelings. That's my commentary on that. All that aside, I don't really hold grudges. Like I have communicated to Layne and through his friends, like Dom D'Agostino, who's known him for 20 years. I'm very happy to bury the hatchet and have a civilized conversation at any point in time if he's willing to come forward and have a nuanced discussion. Others have, from Simon Hill to Professor Walter Willett. If Layne wants to have his turn, I am more than happy to have a discussion with him. But right now, I remain blocked on social media. So that's where things stand.
I'm very much the same way in my sphere. Obviously, I am more in the realm of hypertrophy, but there's going to be certain people that I disagree with at times, people that I agree with at times. But I'm never against people who I might disagree with more than others, just sitting down and having conversations on that stuff. And I really appreciate that perspective from you, just because of the fact that you are going to go through the nuance and you're going to make it more about the data than the person itself. Now, there is one thing I wanted to ask you specifically about the debate when it comes to the cholesterol conversation,
Mm-hmm.
and that is the one that people kind of use as their trump card, which is the Mendelian randomization, which a lot of people just repeat it because they hear somebody say, well, the Mendelian randomization trial shows, the Mendelian randomization trial shows. What would your response be to something like that? And is it a study that you would view as something that's practical for an N equals one area, or is it just something that's been broadly applied to people that shouldn't be applied on an individual basis?
Um, think about this. Mendelian randomization is used when it's hard or impossible to do randomized controlled trials on a thing and is based on genetic variance. That is the basis of it. So, with respect to LDL and ApoB, my LDL is around 90 on a standard American diet. If I'm eating cheeseburgers, French fries, and ice cream, my LDL is 90. Now, if I shift my diet to one that is, you know, rich in avocados, olive oil, salmon, you know, very picturesque, healthy, but very low carb, my LDL will go through the roof. When I started keto, I was eating high fiber, low saturated fat. My LDL went from 90 to well over 300.
Oh,
That
so
was the initial response.
that's even with a low level of saturated fat in the diet.
My highest LDL ever was when my saturated fat intake was extremely low.
Interesting.
I'll explain why that happened. Again, consistent with our model. Actually, I'll just briefly say I adjusted my diet in order to get the saturated fat and cholesterol out of it. So I got rid of egg yolks, butter, cream, all of that because it was early on in the journey. And as a function of that, I also lost some weight, became even leaner, and my LDL went up because of that. So in this context, at least in me, I won't even generalize beyond me to other LMHRs, but like leanness and activity level trump saturated fat. In fact, in our meta of RCTs, we show this, that having a normal BMI has over five-fold the effect that as being in the highest quintile of saturated fat intake in these studies. So in this context, saturated fat, it can affect LDL, but it is not a dominant lever. Other elements of our quote lipid energy model are, including being leaner and more active. Um, Back to the Mendelian randomization studies and the point I was trying to make, which was if these are based on genetic variants and you have a phenotype or response that emerges as a function of something that isn't genetic, like I plot genetically to an LDL of 90. I have a metabolic response, however, where my LDL changes to a very, very different level. And so, what I would say a very, very high level idea is that the etiology, the cause, tends to matter with respect to biomarkers in general. That's a very important context. So I would absolutely not generalize from studies with a genetic basis, genetic variants, to one where there's a metabolic response. An LDL of 300 in a lean mass hyperresponder is happening for a very different reason than dysfunctional lipid metabolism, as in, say, familial hypercholesterolemia, where you have a broken lipid metabolism. And this is something that is very general and very accepted when it comes to physiology and biomarkers. The cause and the context do matter. I can cite studies on this in JAMA cardiology. We can go into like just analogies and examples, but high level, that should not be a controversial concept. Now, what Mendelian randomization can do that I would say is to some degree legitimate is help suss out the idea of causality if something's in a causal pathway. So when you're talking about atherosclerosis, the development of plaques and coronary arteries, as part of the ensemble of literature that would point to LDL particles and ApoB containing particles as being causal in the process, I think Mendelian randomization are fine for that. But then people get confused because they think causal means it's the most important thing and it needs to be addressed. It is not what causal means. Causal does not mean sufficient. Causal does not mean you have to treat it. Causal does not mean it has the strongest association. Causal means it's part of the causal cascade. Thereafter, you have to ask the question, well, what is the absolute risk associated with a particular biomarker phenotype? And that is an entirely different question. So I'm totally on board with saying Mendelian randomization have their place, that they help contribute to the idea that LDL is part of the causal cascade. But it doesn't follow from that that everybody with a high LDL needs a statin, or even that LDL has a very strong association with plaque progression in all patients, because that's not the case. And we're demonstrating that's not the case in lean mass hyperresponders. That's what I'd say high level with respect to the Mendelian randomization. You have to apply them to the right patient populations. Methodologically, they have their limits. And if you want to talk to a brilliant statistician about this specifically, Professor Adrian Sotomoto would be the guy. But beyond that, even if you say causal, like what does that actually mean? That means it's part of a causal cascade. It doesn't actually mean the biomarker is that important or that it needs to be treated in all cases.
So if you were taking a look at the causal cascade and you
Mhm.
were saying, okay, this is the perfect storm in a negative sense for something
Yeah.
like arthrosclerosis. Always struggle with that word. Arthrosclerosis. Oh my, I can't even say it. You know what I'm trying to say.
ASCVD, ASCVD, chronic
ASCVD. Yeah,
cardiovascular disease. You
let's
actually
keep it
sound smarter because you get the acronym in there and you sound very
there.
medical. ASCVD.
Yeah, exactly. So if you had to take a look from your best ability to analyze the available literature, what is your perfect causal cascade that you take a look at and you say this is something that somebody would need to be more concerned about?
Well, it's not so linear as kind of a network. So when we're talking about risk variables, an independent variable would be an ApoB particle count. I would take that into the context of markers suggestive of metabolic dysfunction and insulin resistance, which might not be causal. Things like a triglyceride to HDL ratio. I'm not saying that's causal, but it can be very informative to underlying metabolic dysfunction. And the reason, at least my impression of the reason conversations tend to skew towards ApoB and LDL particles is because, in the game of ASCVD risk whack-a-mole, it's the easiest mole to whack using conventional Western approaches because we have drugs that can target it. Whereas underlying, sorry, I'm having seltzers now, I'm having burps. Underlying metabolic dysfunction and insulin resistance isn't that receptive to pharmacotherapy in general, right? It requires lifestyle intervention or a metabolic health intervention of sorts. And that is more difficult. So we tend to talk about it less because it's not within the purview of Western medicine to treat as easily. It doesn't mean, even if it's not, triglyceride to HDL ratio causal in the same way, it's not informative or important. Actually, there was a brilliant piece by Professor Peter Libby at Harvard on the changing landscape of atherosclerosis, where he makes the point we are innovating ways to lower ApoB and LDL continuously, and on population levels, LDL and ApoB are going down, but heart disease isn't, or it continues to be a problem. Why? Because the landscape of risk is changing towards more metabolic dysfunction, things related to insulin resistance, metabolic syndrome, all that. These things that can really only best be addressed with lifestyle therapy. So, if you are someone who is, quote, metabolically unhealthy and you have a high ApoB and other things that should be considered like family history, it's like you want to do risk reduction. This isn't something that I think you should gamble on, your heart health in general. And so for the right patients, pharmacotherapy for lowering ApoB can be completely appropriate. But it doesn't mean that's the case for all people. And I think nuance is lost in public settings where we have these discussions, and it's usually like academics or self-proclaimed academics sniping at each other because they want to put their flagpole in the ground on something simple that people can digest rather than getting into the nuances of it. My impression is because they don't think people can appreciate the nuances of it. And I'm not going to say it's easy, but that is my best guess as for why you'll hear people say like lower is better when it comes to LDL and ApoB. You hear that all the time from clinicians and academics. And I really don't think it's because they believe that without any further caveats. I don't know how they could, because you have to take into account what are you doing to lower this risk marker, because interventions do have side effects, both known and yet to be discovered. And better with respect to what? Better with respect to cardiovascular disease specifically, or longevity and health span, because those are two different things. So you require a little bit more conversation, but my impression is it's more of a let's hedge on the side of giving the most extreme conservative stance so people don't see an inch and take a mile. And my perspective is people are smart enough to know when they're being patronized to, then they get ticked off, and then they rebel. And that's where you get dangerous behavior patterns. Not saying, look, ApoB is causal, but it's not sufficient. Here's the absolute risk that might be associated with your case, and here are the pros and cons of this intervention. There are cons, but let's quantify them and have an elevated individual discussion on whether or not this intervention, be a dietary change, say abandoning a ketogenic diet if you're a lean mass hyperresponder, or taking a medication, say a statin or other drug, is right for you as an individual.
Yeah,
That's my
no, and that's a fantastic point as far as trying to make it as easily digestible for people as possible. And I find that happens a lot of times when I try to go nuanced on a subject on my platform. What will often happen is people say, "Oh, so you're saying that what you said before was wrong?" I'm like, "No, I'm just saying there is additional nuance that can be added to the topic."
yeah.
And I feel like you're going to deal with that pretty much your entire career because you are a nuanced person. But for the people who, because this is something that I made a post on the other day, for people that are concerned about their LDL and they're like, okay, they're trying to see what does cause it to go up, what does cause it to go down. What would you say? Because this is one that people were very upset with me for posting that I was eating 12 eggs a day. They were very upset for that because, oh man, like you're gonna make your LDL go through the roof, which it didn't. It stayed pretty much the same as it was before. Wasn't really any different for me. And you did one yourself, which was 24 eggs a day. so an even higher amount, and you monitored your LDL during that time. Could you explain the mechanisms by which that
Mhm.
dietary cholesterol did not cause your LDL to raise to any significant levels?
Yeah. So first talking about just the basic physiology, there's a hormone called choline. It's actually very nicely named as opposed to a lot of things in physiology because choline cholesterol inhibitor. That's why it's named choline. It was a hormone discovered actually this year, which is kind of surprising because you think we would have had these things figured out, or at least a paper on it was published this year. And basically, the idea is when you eat cholesterol, it binds to a receptor in your intestines, and that causes the release of this hormone, which goes to the liver and puts the brakes on cholesterol synthesis. So you eat more cholesterol, this hormone goes up, brakes on cholesterol synthesis in the liver. You eat less cholesterol, this hormone goes down, take off the brakes, your liver makes more cholesterol. Pretty, sensible that your body would maintain a homeostasis to an extent. Now, I realize the irony of that when we're talking about lean mass hyperresponders. That's a different sort of homeostasis. We can get into that and the mechanism, but that's the physiology that we are discovering. It's been known for a while that dietary cholesterol doesn't really impact your cholesterol. At a population level, I won't say there aren't exceptions who are like hyperabsorbers. Of course, always there are. But generally, dietary cholesterol isn't really that meaningful for your serum cholesterol. So, in my experiment, I ate 720 eggs in a month. That averages out to one per hour every hour for a month, or 24 per day. And my cholesterol didn't change, at least over the first 2 weeks of the month. The second 2 weeks of the month, I did one more thing, which was I added a little bit of carbs in the form of blueberries, and my cholesterol dropped 18%. My LDL dropped 18%. The reason I added the blueberries was, again, as a metabolic demonstration, like with the Oreo versus statin study, where I'm saying, look, in this case, in the push and pull of eating an absurd amount of eggs, even if you kind of know that cholesterol dietary doesn't really increase your cholesterol, there's still like a provocation element of he's eating a crazy amount of cholesterol. It was
Yeah, of course.
like something close to in total, in addition to the eggs and other food I was eating, like 150,000 milligrams in the month. Compared to that to just I was eating, a few blueberries, like 60 grams of carbs and blueberries and bananas, and my LDL went down by 18%. It's like the demonstration there is in the push and pull of these factors, there is clearly one that is much more dominant in this context. In this case, it was adding back dietary carbs. I did that with the Oreos too. Again, it's a matter of what I said earlier, where if I can engineer circumstances to generate a result that is contrary to conventional expectation, it means that convention is missing something and there is something to be learned. That is the purpose of these demonstrations. It's not recommending people to eat 720 eggs. I can care less what people do individually. It's because people are going to respond to that. And a sub fraction of people or a fraction of people will actually get engaged and want to learn about the physiology. And then there's going to be the trolls that just call it clickbait, and fine, they can do that. The algorithm doesn't really care. I like to say, um, data doesn't care about your emotion. I replied to this once, so it's not something I say typically, but I like this as a troll reply. See what you think. Data doesn't care about your emotions, but the algorithm loves them. Thank you.
Yeah. No,
So
that's incredibly accurate.
it's so if you I'm not trying to hide the fact that with something like that, a stunt like that, I am trying to go after the visceral response, but with a purpose. It's crazy as provocation with a purpose. You put the legit bait, shell, pardon the pun, around, the juicy nuance yolk. You want people to go for the yolk, but like we said earlier, people aren't reading the meta of RCTs. People don't tend to download the primary literature. You have to like bait them to it somehow. And I am not above using Oreos and 720 eggs to do that. I think it's just being a pragmatist in this day and age when if you're an academic who wants to scale the discussion around their literature, you have to find creative ways to do so. So I'm pretty new to social media overall and don't consider myself a career influencer. I am a PhD scientist and a Harvard medical student finishing up my medical degree who's now exploring how to communicate science to the public at a really unprecedented time. And it's just fun for me to be like, okay, I'm engaged in the science. Okay, I'm learning medicine. Oh, and I have this new thing available to me that no generation before did, which is an incredible set of platforms to communicate with broad audiences. And not only do I think that's fun and important, I think it's a responsibility because we are living in an information age where people will have access to information. And the currency of the realm is engagement and clicks. That is the reality of it. There's no two ways about it right now. So you can be an ideologue and kind of sit on the couch and moan about it, or you can say, all right, here's the reality. How am I going to compete in this space to provide what I think is value add? And I'm not going to say I always do that perfectly, but that's what I'm trying to learn to do.
Right. Well, in these N equals one experiments that you do on yourself, they essentially what they do is they bolster conversation.
Yeah.
And that is really what we should be going for because people and it drives me absolutely insane that I have to be a little bit inflammatory almost all the time in order to make ideas go further. But I tell people all the time, I'm like, there's a lot of black, there's a lot of white, but there's a heck of a lot more gray. And people hate spending their time in the gray. They're like, just tell me one thing or the other, and there's no area where they can actually meet and have reasonable discussion.
But you can capitalize on that. So
Yep.
that was the core of the Oreo versus statin experiment, which was here's the deal. I'm presenting you with what we can agree on is an unhealthy intervention. Does anybody think actually eating Oreos on top of your baseline diet, a sleeve a day, is healthy? I would hope not. However, there was a response, a dramatic drop in LDL that a lot of people would presume to be healthy. So when I present you with unhealthy intervention with healthy response, there is a clear tension there, a clear and implicit tension, and that creates a cognitive dissonance, which people are very uncomfortable sitting with. So what results typically is people putting words in your mouth. Oh, Nick is saying something about the value of statins or the value of LDL. You can look through the paper, the coverage of the paper that I've done. At no point in time do I make a value judgment on LDL or statins. People come to the video and they're uncomfortable sitting with that cognitive dissonance, so they layer on an interpretation.
Right.
The fact of the matter is, that's predictable. I don't really see it as a problem of responsibility from my end because it's going to be layered on in a manner consistent with confirmation bias, such that generally opinions will not be changed. But then
Mhm.
I go to those people and I have to say, well, I didn't say this. Why did you feel the need to superimpose that perception rather than doing what I really want you to do, which is say, well, here's what I perceive to be a paradox. That's interesting. Let's
Yeah.
try to resolve that. Or just get curious about it and then engage in the process of scientific discovery. Because where we are with our models is at very early stages of, let's say hypothesis testing and rigorously developing this field. If it is as revolutionary as we think, there will be several or many multi-million dollar studies, some of which we might even have in the pipeline, knock on wood, um, investigating this. We haven't had the time to run those. It'll take a while to run, even longer to publish. We're not going to keep you insulated from the information in the meantime. I want people to engage with the scientific process and go on the journey because I think that is a right and privilege that everybody should be entitled to, provided that they are just willing to come with intellectual integrity, authenticity, and enjoy the scientific exploration. I think being a scientist is just about being curious. And I think being curious is something that is intrinsic to humanity. And to be a full and complete human being, you need to express some degree of curiosity. Otherwise, what are you?
Well, there's a complete misunderstanding amongst the general population as to what science is. A lot of people seem to believe that science is okay, there's a topic, you do a study on it, you find the answer, and you know. From one individual study or even a few different studies, you know because of this. They don't understand that essentially what we're doing is just interpreting data and trying to interpret it to the best of our abilities. And as we develop more and more data, we can become more and more clear in our overall opinion.
Mhm.
But there's a ton of very contentious topics within my sphere, which is hypertrophy, where a lot of people are trying to get me to plant my flag in one side or the other. And I'm like, you know what? I know what things are effective for training. I've explored them, I've done them over and over again. And people want to know, they're like, well, is it by this mechanism or this mechanism? And here I am, I'm like, guess what? In the end, even if I was to plant my flag that it's this mechanism, that would not change the way I'm actually going about things in order to make things happen. And
Yeah.
I feel like that's the way it goes for things like this because what happens is here you are, you probably have a relatively high LDL on a consistent basis, right?
Mhm.
And you're not sitting here saying, "Oh, well, because my LDL is high and because there was studies over here that said this, I have to try as hard as I possibly can to make sure that it's low all the time." and you're taking it on a more individual basis and figuring out what your overall lifestyle habits have to be in response to the overall markers. Is that a correct way of putting it?
Yes, but I would add to that that I can interpret the literature with respect to its relevance to me. And like people tend to say this will be the comeback to a lot of our literature. So, for example, we just had a paper come out in one of the Journal of the American College of Cardiology journals, JACC Advances, on people like me, lean mass hyperresponders, who had an average LDL of 272, had been on a ketogenic diet for an average time period of 4.7 years. And the main findings were there was no increase in plaque as compared to a matched control group, and there was no association between LDL and plaque progression. Now, I can't speak to the finer tuned data, which actually after this meeting, I have a meeting around that, but let's just say that's only the tip of the iceberg. Now, that said, these data are preliminary and it's a small
I
data set. So
I have to stop you for 1 second because I just realized we actually didn't tell people what LMHR means from a numbers standpoint.
the threshold. Um, the thresholds are LDL above 200 milligrams per deciliter, HDL above 80 or equal to or above 200, equal to or above 80, and triglycerides less than or equal to 70.
All
The
right.
study I'm talking about now had a little bit more liberal cut points, so it was LMHR and Neil LMHR, but um, basically the findings were, as I mentioned, no increase in plaque as compared to a matched control group. We are going to be following this group prospectively as well, and there was no correlation between plaque score and LDL. Now, there are caveats to these data. This is not a perfect study. There are no perfect studies. It is also preliminary. So one could fairly say, okay, this is just one study, but the preponderance of evidence, you'll hear academics say this, the preponderance of evidence, by which they mean the body of existing evidence, which is huge, decades, thousands of papers, say something else. What I say to that, and this gets back to, me making my individual decisions, I'm like, well, yeah, but none of those data, zero of the preponderance of evidence you're talking about, was collected in the population at hand.
Right.
So if you want to draw conclusions about a particular population, you study that population. So even if you have one study with preliminary evidence on said population, if all the other data are on very, very different populations, which is the case here, then what are you going to run with? And for me, I fall into a category that is something that just genuinely is grossly understudied in the literature. So I can see the MR, Mendelian randomizations, take them for what they are, draw conclusions from them about the general public, and then distinguish myself as an individual which doesn't fall in to the same phenotype, the same category, and has other considerations. And also, of course, like any human being, weigh the pros and cons of specific interventions, be that lifestyle change or pharmacotherapy, for me in my context, given other priorities, medical conditions, things like that. And so it's one thing in the abstract to say, oh, yeah, you should snap your fingers and drop your ApoB, but it's like, well, what are you going to do and what are going to be the costs? And then that is an individual discussion. Um, so, yeah.
Can I ask you specifically, were you into the science and the research of nutrition first before you started implementing stuff for yourself, or was it what you implemented for yourself drove you towards the science?
I'd always been very much into physiology, but in terms of what people would call nutrition science, that followed on me adopting a ketogenic diet for inflammatory bowel disease, which I did as a last ditch effort. Like I was in ICU level PAL care level care in the UK when I was doing my PhD, at least at a point in time for inflammatory bowel disease. And I had tried every possible thing you can imagine under the sun, and nothing was working. And so I got desperate and tried a bunch of different diets. A ketogenic diet worked for me, and that's where I just got curious about what I tend to call metabolic health science, which includes nutrition, isn't exclusive to it, but also because I think I love nutrition science, but let's be real, it is the most diluted cesspool of crap study science probably in the literature. And
Yeah.
so and frankly, I'm saying that because that was my opinion prior to really delving into the hardcore metabolism, which is like, yeah, my parents are doctors, like I'm pretty smart. I've read the guidelines, like I know what healthy looks like generally, and I know how to eat a balanced diet and about, micronutrients and macros, yada, yada, yada. I couldn't have been more wrong. And it's difficult because to break down just how skewed we are, which we can do maybe in a round two where we spend 4 or 5 hours on it and we come up with examples, including in the peer-reviewed literature. We are really led astray. And it's to the level that if I were to talk to myself, if I were to talk to my 20-year-old self and tell that person what I knew now and try to do it in 20 minutes, I would have thought the person talking to me, my older, maybe wiser me, was a conspiracy theorist. Like it's that level of screwed up. To the point that I read studies right now and I'm like, I don't know how this got published. This is clearly written in a manipulative way. And I mean, the title is just a frank lie. We have examples of that. There was one, this was an abstract, it wasn't full paper, but it's published in the Circulation, a top cardio journal. And the title was something to the effect of, just to give an example, um, rapid progression of coronary artery disease in a person who stopped in a lean mass hyperresponder who stopped a statin and went on a ketogenic diet. So there's clear. This is an example. Clear claims of this person had rapid progression of cardiac disease after stopping a statin and starting a ketogenic diet. That's a claim, and they're claiming this is a lean mass hyperresponder. You then read, which is just a like 4 or 5 paragraph little short thing, so it's not hiding. And it's like, okay, first of all, not a lean mass hyperresponder. You miscite the criteria, but even misciting the criteria, it's not a lean mass hyperresponder. Also, then you looked at the patient's history, and it was like, wait a minute, this person didn't have rapid plaque progression after stopping a statin and starting a ketogenic diet. He had a pre-existing severe occlusion that they went in to intervene. So there's multiple arteries in the heart. They had a near occlusion of an artery, so they went and did an intervention. While they were doing that intervention, bear in mind he's never been on a ketogenic diet up to this point. While they were already in his heart to presumably open a artery, they were doing a percutaneous intervention, PCI, probably putting in a stent. They also noticed he had moderate disease in another vessel. So they put him on pharmacotherapy, in this case, a statin. They then let him go into the world for multiple years while he's on this drug. They're not monitoring him at this time. They're not monitoring for progression. Then at some point in time, they don't say really when, he stops the statin. He stops the statin and starts a ketogenic diet. What they don't say is what the ketogenic diet was. So it could have been he said he was on a ketogenic diet, but he was just eating Quest bars, having milkshakes and bacon for a week because they don't say how long it was either. So multiple years of this pharmacotherapy, statin, while he's not being tracked, then he tries a ketogenic diet, undefined, unknown duration, and then he has a occlusion of the vessel that was already partially occluded during the other event. So you can see how manipulated that is. Like, first of all, he's not the phenotype you're saying he is. And then the
Right.
case history is such that he has severe heart disease. He's been on this drug for years, during which the disease could have progressed because you weren't measuring it. And then he, quote, tried a ketogenic diet, but you're not going to tell me what that is or how long he was on it. It could have been a freaking week. And you're going to pin all the blame on the diet and mislabel him as a phenotype he's not. And then publish this in a top cardiovascular journal. And that's one example of I can come up with dozens, literally dozens. And to some degree, it does seem intentionally manipulative.
Yeah.
There, what I will
I
say is there's clearly double standards in the literature, and
yeah.
people wanting to build particular narratives, which is pretty easy to do if you lean into the status quo.
And there's no sense in which I view you as a conspiracy theorist for talking through this stuff because I see it all the time in the literature that I encounter. Like I said, like my primary area is hypertrophy, and I will see meta-analyses, quote unquote meta-analyses on a particular topic, and I will go through and I will see, I'll be like, they literally left out 5 studies that are relevant to this topic, and they
Yeah.
picked 6. I'm like, but they didn't say why they left out these studies, and these studies contradict it. And you see this all the time with
Yeah.
various authors.
I can give you other examples as well. I know one thing that people were talking about recently was there were a bunch of two studies, not a bunch, two, that came out about red meat and diabetes. Now, First thing I want to say when it
I
comes
was
to
going to
red
ask
meat.
you about that specifically. So
First thing I want to say about when it comes to red meat is this is a topic that bleeds into so many topics, be it, the climate, animal welfare, and then areas of health, heart disease versus diabetes, whatever. That's fine. We can acknowledge it's a complex topic. Whenever we're talking about studies, I want to focus on, as best we can, the topic at hand. So here, the topic is red meat and diabetes. Okay, so let's narrow in on that, try to leave your biases with respect to other animal related things at the door and just say, what is the claim being made by this literature or the coverage of this literature? And basically, there were associations between red meat and diabetes. I've done coverage on it. You can look at like the detailed breakdown on my YouTube channel. I'll focus on the one paper that was the bigger paper for now, which was published in one of the Lancet journals. So a very top tier journal. And it was a meta analysis. Again, you hear this word of 31 cohorts. So it sounds nice, right? Meta analysis in top journal. It sounds authoritative. On top of that, it was like an unprecedentedly large number of participants, something like 2 million. So you can see how it's very easy for people wanting to build a particular narrative to cite the virtue metrics, that it's a meta-analysis in a top journal with lots of people. And then, say a claim they want to say about red meat and diabetes. And this is what happened, where there were media outlets and also influencers kind of abstract and title bombing their followers. And it's effective at getting engagement. But you look at the literature, and there were a few things I'd highlight about that particular study as an example, which was one, the effect size was tiny. It was a hazards ratio of 1.10 for red meat intake per unit. By comparison, just having a BMI over
for for
so so
my for my
yeah,
audience, explain what a hazard ratio of 1.10 means.
it is the ratio. So basically, 1.0 is a neutral. Lower than 1.0 is reduced risk. Greater than 1.0 is increased risk. So it's zero point 0.1 above 1. So very, very small effect size, like a 10% increased risk as compared to something like the risk ratio for having a BMI over 30 for type 2 diabetes is 4.44.
Yeah. And
So,
10% relative risk is what you're talking about, correct?
yes. And in terms of HRs, that's pretty small.
Yeah.
Furthermore, if that was the only gripe I had, 10%, 10% isn't nothing. By no means is it nothing. That is not the only gripe. I'm going to mention a few things, and I want you to take them as a comprehensive. So small effect size, generally small effect size. Two, study heterogeneity. So there were 31 cohorts or cohort heterogeneity. 21 of the 31 showed no effect. So
Hmm.
the majority of studies showed no effect, and some were actually trending towards reduced risk. So the effect was driven by a few studies, and then you end up with this small effect. So there's already like controversy within the data set. The majority of studies showing no effect, and a small effect size. We can comment on the whole idea of meta-analysis and why it can actually be misleading, but take those two things. And then on top of that, you have confounders. So between these two studies that came out, you look at like the high red meat or high proxy for red meat, say heme iron intake groups. And there will be things like more smoking, more obesity, right? More sedentary. And so those are major confounders. Remember, we said for obesity alone, the risk ratio is way, way bigger than it is for red meat intake. And then take into account the fact that because there are these huge confounders, what you want to do is statistical adjustments. And you can try to do those, but effectively those are best guesses, right? You cannot be confident the adjustments are going to be perfect for any metric included. And when it comes to things like obesity and smoking and physical inactivity, you're also not going to be correcting for other, quote, healthy user bias factors. So I would absolutely not assume that confounders have been accounted for, at least not completely. So you combine cohort heterogeneity. In fact, most data in the data set actually say, or most of the studies say there's no association. Then the fact that it's associational with a small effect size and there are confounders. And on top of that, the biological plausibility is a little bit weak. You combine all that, and it's a bit of a nothing burger, pardon the pun, right? It is not, there's no real basis to claim red meat causes diabetes. Now, I won't say it's not possible. So the one other study was based on heme iron. I'm not going to say it's impossible that excess heme iron couldn't cause oxidative stress and, in certain circumstances contribute to the pathogenesis of diabetes. I'm curious. It might actually be legitimate physiology. But when it comes to the low-hanging fruit of, what people should take away now in terms of diabetes treatment and prevention, these data absolutely do not say target red meat intake as, the low-hanging fruit to reduce your risk. That is reduce, sugar and refined grain intake and or refined carb intake, and then, weight management as best you can. And if that includes more red meat, fine. So again, an example where the data definitely get misconstrued. And what I would say is it doesn't mean the study is bad. Like the
Mm.
Nature Metabolism study on heat iron wasn't bad, but it's how it gets manipulated, interpreted, and then the fact that there's a bias towards publishing what is in the mainstream. And then the mainstream amplifies that with extreme narratives, generating more interest and incentive to publish more of what's in the mainstream. And
Right.
so you get this vicious cycle doubling down on conventional points of view. And that is a problem. It doesn't mean, like, I do believe in the end, the scientific process wins the day, but people need to understand that, like, the peer-reviewed literature is not a meritocracy. It's not infallible. There are human beings behind this with their own biases and incentive structures at play to bolster generally mainstream narratives.
Mhm.
Um, so
I always find it funny when you get to the end of a study and it's supposed to list any possible biases and stuff, and then it says nothing, and you're just like, I mean, yeah, you can say that. You can say it because obviously what
yeah,
they're mostly referring to is the very,
primary.
very obvious ones out there,
Yeah.
but it's like there's going to be bias in pretty well
Yeah, and
everywhere.
we can acknowledge that. And some of it can get really nuanced and complex. We did one reanalysis, for example, of a study that was published in Nature Medicine. It was a pretty famous crossover trial looking at low carb, quote, animal-based diets, although it was pretty terribly designed animal-based diet versus low-fat diet, plant-based low-fat diet. And there was a claim that the low-fat plant-based diet led to less energy intake and more weight loss. And this is where I just want to like highlight how fine these errors can get going beyond media headlines. There was literally a line in the methods about something called diet crossover effect or diet carryover effect. And effectively the claim in the original paper was a lie, and the diet carryover effect was so large. There was basically this confounder that was so massive that it was 3 times the size of the main effect, completely invalidated the main effect. Again, something we can dig into in more detail, something that I've covered, well, in our literature, but also on my channel in a little bit more detail if you want to get into nitty gritty. But the reason I bring up this point is because in the case of that particular study, but in a lot of studies, it then sets the groundwork for future studies that then cement that perspective. Resources are spent going down that direction based on a misleading foundation, which, let's just say, without making it too personal, narratives built uh, are easier to defend than they are to overturn, even when the data seem very clear on what the right answer is. That there is a lot of there are alternative incentives and drivers determining what gets amplified and what doesn't beyond just the data themselves. And at a high level, I don't think that's something that people should find controversial.
Right. No, I 100% agree with that. I mean, part of the reason I got into the nutrition field in the first place was because my personal history was kind of similar to yours where it was like a last ditch effort because I was like I can't figure out why I don't seem to be lining up with what I'd heard my entire life when it came to the nutrition, which was essentially I was dealing with extreme constipation. Like just incredible levels of constipation. And what I was doing was I was actually taking and I was doing what a lot of the people told me was the thing that you do for nutrition, which was more fiber,
Mhm.
throw more fiber at it. And it was getting worse and worse and worse. And I could not figure it out. And finally, I stumbled across one random paper out in the middle of the woods that was like when they took the fiber down from people who were dealing with this extreme constipation, it relieved their symptoms within a week. I was like, well,
Was it a 2012 study in the journal, like World Journal of Gastroenterology?
I think it was.
Had like
And
an orange border or something
yeah,
online.
and I was
That
like,
study has circulated so much and helped so many people. You are not the first person to tell me this.
I was like, you know what? The only, because I was still trying to watch what I ate. I was like, the only way I can think to do this, to get rid of fiber without going on a processed style diet,
Yeah.
is carnivore. That was the only way I could think of to do it at the time. So I went carnivore for about a month,
Yeah.
and my symptoms were gone within 2 or 3 days, and I felt amazing. I like
Yeah.
the best I'd felt in a very long time, and it was one of those things where I was like, that was what got me curious. That was what made me curious in
Yeah,
the first
right.
what other things, what other nuances are we missing
Yeah.
overall?
Did you read our Carnivore for Inflammatory Bowel Disease paper?
I didn't get a chance to read it yet.
So we just had a paper out in Frontiers in Nutrition on a carnivore diet for inflammatory bowel disease, which isn't just constipation, but it's like ulcerative colitis, Crohn's disease. But I mean, you should read it because you get a. In fact, even if you just read it, it's totally open access. You can skip to. We go through 10 patient case histories. We have some synthesis, but you can go to the end of each section, and the patients each can provide a quote. So
Oh,
you
I
can
think
each.
so. I actually saw your video on it.
Yeah.
I didn't read the paper, but I saw your video on it. Yeah, I remember that now.
So I like that patients can give their patient perspective because a lot of it is like you're desperate, you try something that's kind of fringe, and then it works, and you're like, oh shit, pun
Hmm.
intended. Like this worked. That's weird. And on that particular topic, it's like, take the carnivore diet. It sounds extreme and crazy. And I get that. I can put myself in the shoes of the person I was before I really delved into metabolism science. And I get why that sounds so absurd. At the same time, pause and consider first that there are a bunch of clinical narratives around this with people like you, people like the patients in this case series saying they had beneficial effects. Frame that by the fact that there actually is hardcore physiology supporting why and how this could work. So, for example, in inflammatory bowel disease, higher ketone levels, which you'd achieve on a carnivore diet versus a Western diet or mixed macro diet, are associated with less inflammatory bowel disease activity in clinical cross sections. Um, there are mechanisms by which ketones are anti-inflammatory. There are also mechanisms by which fiber elimination can be therapeutic in inflammatory bowel disease. This has been shown. In fact, fiber-free liquid diets have been used for treatment-resistant pediatric cases of inflammatory bowel disease because removing the fiber, it's been shown, this is a 2023 paper, I think, in Cell, Host, and Microbe, changes the microbiome landscape where even like this pathobiont, pathological microbiota bug, just it changes its geography in the gut and its metabolism. Um, and so if you have physiological plausibility along with accumulating clinical narratives and the fact that there isn't data against this, there's just no studies investigating it. So it's a matter of absence of evidence isn't evidence of absence. And when you consider then the research infrastructure and the fact that there isn't the incentive structure in place to want to do a very rigorous trial, say for a carnivore diet versus a whole food plant-based vegan diet, which would be a multi-million dollar study, who would
Right.
make who money and hasn't been done, then you can say, okay, this isn't standard of care. We understand why it's not because the best studies that need to make a standard of care haven't been done. Totally accept that.
Right.
However, you can't say that there isn't reason to believe it would work. Actually, there's all the reason to believe it would work. And then the question becomes, well, how are we going to prove that? How are we going to actually pull off a rigorous trial since nobody else has done that before? My answer to that is start the discussion with something, say a case series, which is what we did, and then try to find ways to pull the trial off, which again, somebody wants to give me $4 million, I can do it. I don't have $4 million.
Yeah.
And so it's a matter of, this is bringing it back to a theme you might see with me, be it the 720 eggs, be it the Oreos, be it the carnivore case series. You have to find in this world innovative ways to, you know, get yourself to a position where you can have the discussions and also do the research that is going to change the world. That is difficult. It is particularly difficult for a 28-year-old, which I am, without all the resources in the world. I know what I am. I know where I am in my career. So I'm doing what I can with what I have. And hopefully 10 years down the road, we will have converted some things like the Crazio Oreo versus statin study into something huge. Actually, I will say, because I'm not even going to name the group we're working with, but we're designing a $1 to $3 million study with a very reputable group at a well-known US institution that is going to be doing a study that includes a component that is effectively the RCT version of Oreo versus statin.
Really?
Um, yeah, I can tell you offline the details if you want. I won't draw the researchers' names into it right this point in time. But again, it arose from connections I made after doing the Oreo versus statin study. So you people get to see the tip of the iceberg in like social media discussions, but realize there's this whole back strategy to it where people that don't necessarily get vocal on social media but are thoughtful be like, there might be something to this.
Yeah.
Let's have a talk. And a serious talk like we're having now, where we speak for a few hours, is not necessarily recorded, but devoid of all the social media filter and the idea that people are watching you and you're trying to get clickbait and engagement. So I have fun with my trolls. I have fun with my fans around Oreo versus Statin, 720 eggs. There's a much bigger game at play beyond this. I'm not doing this just for clicks.
Well, there's actually a lot of other people who are in a similar boat to you in the sense that they understand stuff on a deeper level. And I have been working my butt off to get some of these people to understand social media better because they don't understand what this can actually do for their ideas or for the how this can actually change the landscape. They're like, oh, well, I just don't understand social media. I'm like, let me teach you. I will help you
It's
develop it so we can get these ideas out there.
right. And maybe it requires a little bit of young blood to do it. Because it's like, I
Maybe.
mean, I've talked to people in my parents' generation, they just like don't get it. And there also is, just to understand, like in the academic community, a purism about it. Like I am above social media and playing these games. Fair enough. I get that. I get not wanting to get into the weeds of like legit bait, clickbait, whatever. At the same time, I like to try to take the practical point of view, like what you said. It's like, look, I can shed blood, sweat, and tears for this research project. I can spend years on it, go through the pain in the butt peer review process, pay absurd open access fees, get the paper out there. But if a paper is published and nobody reads it, was it ever published? You know, like the whole tree saying. So
Right.
then the next stage of the game is like, let's get people to learn and talk about the research we're doing. And I'm actually learning to have quite a bit of fun with that process.
Well, and part of the reason I got drawn to your platform in the first place is you would do these studies, you would get the data, and a lot of people in your shoes would then use this to make grandiose claims that are beyond the scope of what it actually shows. And that's what I liked so much about your, because I'm very much the same way. So when I did this little experiment for myself, the carnivore, like,
Mhm.
and it fixed things for me, I then figured out over time how to add things back into my diet without causing issues. So like I figured out like there is it's not like a strict thing where I have to be living in a certain way, but it was something that got me curious in the first place. But I'm also not going to be the person that goes and proselytizes now and says, you must do this in X circumstance because it happened to me. And
Yeah.
and that's part of the reason why I wanted to get on this call with you is because I saw you consistently. You would show something that's pretty out there, but you would not then take and extrapolate that to something that you can't based on the
Yeah.
available evidence.
No, there is an art to putting provocative packaging out there that is actually consistent with your message, but then maybe taking it in a different direction. An example I would say, for example, like I like to say calories don't cause obesity. In fact,
Mm,
one of my first, I'm new to Instagram, but viral like posts was basically like Elon Musk said calories cause obesity or something like that. And I basically said he was wrong. And people got all up in arms.
yeah,
And they're like, it's thermodynamics, but here's why I want to dissect that. It's like the way I see it is I could imagine the thumbnail around it, make a YouTube video that would be very clickbaity and on the surface would make it seem like I'm saying calories don't matter. But
right.
calories don't cause obesity and calories don't matter are two very different statements because of that key word, cause. So
Yeah,
when I see the word cause, what I see is a claim with respect to pathophysiology and biology. And something like the energy balance equation actually doesn't really speak to that. You can have the energy balance equation be maintained while having upstream drivers of changes in energy balance. So how your fat or how your energy for your body is partitioned. Is it into energy output? Is it into voluntary or involuntary? So it could be like body heat, non-exercise activity thermogenesis, stored in lean tissue, stored in fat mass. And downstream of that, you have things like compensatory energy intake, more hunger, or increased energy output. So the calorie balance equation can hold while calories aren't actually the quote cause of obesity. Like if
Right.
it's a car, calories are the wheel, they're part of the process, but they're not the driving wheel. They're just the tires, so to speak. And they're kind of
Every
along for the ride and part of the process and necessary, but I wouldn't call them cause. But you can
right.
see the juxtaposition between the soundbite, calories don't cause obesity, and then what I'm actually wanting to get into.
Well, that was one of the things that I was kind of alluding to when I talked to you earlier, because I've made videos about calories in, calories out, and what I've done is I've explained nuances behind it that people don't fully understand at the moment. And the minute I start explaining nuances behind it, it's all so calories in, calories out doesn't work. I'm like that's not what I'm saying. It's like what I'm explaining to you is how these things are working and how they play into each side of the equation and how this leads to an outcome. It's like, but they don't, as soon as you try to make it beyond, as soon as you try to make it beyond like a calorie that's labeled on a package is the exact same, it's going to have the exact same metabolic effect everywhere else. All of a sudden, you're going against what people believe. You're going against science. Like, no, I'm explaining to you the nuances behind this topic, and
Right.
that's a tough one to get around,
Well, the question then arises, is it your responsibility to service the people who aren't willing to go to the deeper level?
right?
Because I would say we probably explain things in a way that a person of average intelligence without significant scientific background could probably get the main legitimate takeaways if they spend the effort to do so. But if somebody jumps to, no matter what you're going to say, I've seen the thumbnail. I'm sure you have these things all the time where, like, you have a thumbnail or something, and you can tell based on the reply, you didn't even watch the content. You were
Yep.
literally replying to the thumbnail.
Yeah.
Um, and sometimes people do that. It's like, for those people, like I said before, the data don't care about your emotions. The algorithm loves them. Bring it on. So, like, I don't feel responsible for the people that are not willing to actually invest effort in trying to digest what I'm trying to say and come with, legitimate thoughts. And those thoughts can be constructive criticisms. That's fine,
No,
but they have to be deep.
I'll often tell people they'll say some people will get very angry at certain things that I talk about, and they'll get very rageful and so because they haven't really fully understood what I'm talking about, or they're just coming in with a preconceived notion. People are like, "Well, you could have said it in a different way." They're like, "Why didn't you?" I'm like, "Because of you. Because of you. You are driving this to more people who are going to be reasonable and actually allow me to flesh out these ideas more fully."
Yeah. If
But
people are predictable, even if you tell them what you're going to do or they're doing what you want them to do, they'll still do it.
yeah. And I know you said you have to go. You have a meeting that you have
Mhm.
right now. But just to kind of whet people's taste buds for next time, I would love to talk to you about obesity and pathogenesis related to that in the next conversation because that's something that I feel is just not, unfortunately, especially within my sphere, because everything is about bodybuilding style
Yeah.
lifestyles. There's a very big misconception between the difference between prepping for show fat loss
Right.
and overall trying to deal with general public and how people respond to that stuff. So I would love to talk with that about that
Yeah.
stuff with you. And
That
I think you give people a lot of good perspective on that.
Absolutely. That's something definitely to dig into. We can talk about calories, GLP-1s. I've actually had a
Yep.
lot of fun studying GLP-1s from a
Same.
scientific perspective. I think people get very wrapped up again in like the societal implications and the way I like to take things. You seem like a guy who's like similar. It's like, look, there's cool physiology here. Let's talk about the physiology and then leave the judgment out of it and let the like clinical management go to the doctor's office.
Right.
And anyway, so there's a bunch of cool physiology we can learn about. Um, get into the nuances of what causes obesity, and also I think the key thing we should focus on for that discussion is where people get confused and tripped up. You alluded to it, like in the distinction between like bodybuilding prep versus like chronic management of obesity.
Right.
And I guess the one thing I want people to chew on, and this is a broad truth with nutrition science, acute doesn't equal chronic.
Yep.
And I just want people to like think about that prior to the next discussion because it is such a fundamental truth with respect to, physiologic adaptations to calorie or macronutrient shifting to basically everything else. Like acute interventions almost never translate into chronic results. So
Agreed.
something to think about.
Yeah. Well, hey, Nick, I appreciate you taking the time to sit down. I know we had some scheduling issues, but
This was great.
I feel like this is going to happen quite a few times because both of us
Oh
love
yeah.
love to talk through this stuff, and I know that you can give a ton more knowledge in specific fields as far as energy metabolism, GLP-1, all this stuff. I think
Yeah.
your perspective is going to be invaluable for my audience.
I really appreciate it. I'd love feedback from your audience. I know I like to get wax academic and monologue, but yeah, let's collect some questions and feedback and comments from them. We'll hit the obesity topic, and you know me, I love to talk. I'll jump on and chat about whatever metabolism related. So thanks for the time.
All right, I'll see you in the next one.
See ya.